So here are my disclosures. So I have some grant funding. I adjudicated some events in the ESCAPE trial. Wasn't paid for it. As Noreen was saying, I volunteer some of my time to work with the American Heart Association on a program called Get With the Guidelines. And I'll explain a little bit about that program in a little bit. And I co-chair Canadian Best Practice Recommendations for Stroke. So major programs to improve door-to-needle times that are aggregating hospitals together to try to move the needle, reduce times. Well, we're participating in the Quicker program, and I'll tell you a little bit about the American Heart Association, Get With the Guidelines, and their Target Stroke program, which is designed to reduce door-to-needle times nationally in the U.S., as well as what's called the SITS ISTR registry, which is a European registry with more than a dozen countries and several hundred hospitals. Also have aggregated data on tens of thousands of TPA-treated patients. They've recently expanded to Asia and South America as well. So I'll put some of our times in the context of what those programs have done. And all of us have been inspired, by examples at single hospitals where they've gotten really great, door-to-needle time. So this paper, Neurology, is one thing that really galvanized the stroke neurology field when we saw it come out, because no one really thought that you could treat patients in as little as 20 or 25 minutes. But this single hospital in Helsinki in Finland showed that it's possible to do that. And then what the story has been since this paper came out is that a lot of people have gotten together to try to collaborate and figure out ways to achieve these kind of times, including in Canada, where Noreen was the author of this call to action or call to arms. Let's go for a new benchmark time of 30 minutes. And as you heard, we're so close to achieving that here in Alberta. This slide, I guess, kind of says it all, really, in terms of how we're doing. Each dot is the median door-to-needle time, so it's the time at which half patients were treated at that time or less in these two other big registries. The blue dots are from the SITS registry in Europe. And the kind of orangey dots are from the Get With the Guidelines stroke program in the United States. And these are from publicly available data, so they're aggregated from papers. And so you can see it goes back about almost about 10 years, back to the early 2000s. So the median time in the Get With the Guidelines program in 2003 was about 85 minutes. So more than half the patients were being treated longer than 85 minutes after stroke. And then by 2009, it improved a little bit, down to about 75 minutes. And their more recent times, they've just crossed the barrier of the 60-minute barrier. So now in the United States, more than half of patients are being treated in less than 60 minutes. That's data from 2014 and 2015. If you kind of draw a slope between these lines, it kind of goes down here. So you can see that times are improving faster now in the U.S. That's probably related to this Target Stroke program that I'll show you some data on that was presented at the International Stroke Conference recently. The blue dots are from the SITS ISTR study in Europe. And as you can see, in 2004, the median time was 70 minutes, so they were a little better than the Americans. And then from 2004, really, though, to 2011, times didn't change much at all. They were stuck at 65 minutes. It was even slightly higher, 70 minutes in 2011. Now, they've started a program called SITS Watch, which is a program like ours to try to drive down door-to-needle times, and they haven't published it yet. The results may be presented in May of this year at the European Stroke Conference. I'm not entirely sure, but we'll see what happens here where there's a blank area. And then in Alberta, I didn't have too many older data from Alberta, but like Tom or Mike might. But in 2004, in Alberta, the median time was 81 minutes. So we were a little better than the Americans, but maybe not quite as good as the Europeans at that point. And then as you heard from Noreen, we're just kind of barely above that 30-minute threshold. And so you can see where we are related to these other programs. I mean, there's a huge gap that we've opened up on them. So we really should be proud. So the Target Stroke program is the U.S. national program to try to reduce door-to-needle time. So it was launched in 2010. The interventions, now this is carried out at more than 1,000 hospitals nationwide in the United States. So we don't have the opportunity to get everybody together in the same room like we can in a smaller region like Alberta. So the best practices and other communication was really disseminated by the web or by webinars. So there was a paper on best practices. There were decision support tools available online, so you could, and hospitals would be sharing, different like protocol documents, protocols, pathways, checklists, this kind of thing. There was an award recognition program in phase 1, which went up to 2013. Hospitals could win a Target Stroke Honor Roll Award if they treated more than half their patients, of their TPA-treated patients, they treat more than half within 60 minutes. And then since 2013, a phase 2 has been launched, where the goal is to get door-to-needle times in less than 60 minutes in 3/4 of the patients and get a median time of less than 45 minutes in half. So not quite as ambitious as our goals. These are the results to date of the program, and these were presented by Greg Fonarow at the International Stroke Conference, which was in February in LA. And this shows the time trends. So Target Stroke Program is initiated here, and you can see this bend in the curve. And then phase 2 initiated at this point, and you can see, again, it looks like a little bit of an upward bend in the curve. And the table down here, showing the yearly percent increase, so the number of percent more people that are treated within 60 minutes. And most recently in 2015, the median time went down to 57 minutes. So they're treating more than half within 60 minutes, but still not at their goal of treating more than half within 45 minutes. And this shows the proportion of patients treated within 45 minutes. And as you can see, they're treating about 30 to 35% within 45 minutes. So making improvement in this U.S. nationwide program, but not the kind of improvement we've seen so far in Alberta. There was a paper published on the results of the programs, published in JAMA, and it showed the improvements in times and also associated the improvements in times with the patient outcomes. And because this is a large registry with about 35,000 patients analyzed as part of this paper, we were able to see, we were able to link the improvements in door-to-needle times with the improvements in outcomes. So this slide shows the adjusted ratio for a number of hospital discharge outcomes, mortality, percent discharged home, percent who were ambulatory at time of discharge, and complication rates before the Target Stroke Program is launched and then after the Target Stroke Program is launched. In this case, odds ratios that are less than 1 indicate an improvement, like less people with unfavorable outcomes, like in-hospital mortality. The odds drop by about 10%. Discharge home, the odds increase by about 14%. No significant difference in ambulatory status. Importantly, the number of patients who had symptomatic intracranial hemorrhage went down after the program was launched. So that's an important safety outcome, right? As we're going faster, there was a potential concern that maybe going faster would lead to more inappropriate treatment or treating patients with contraindications. You might see more hemorrhages, but that didn't happen in this large program, nor did it happen in the SITS program as well. So there really isn't any data that treating faster is unsafe. So that's important to know. And there were a couple of papers presented at the ISC looking at the improvements in different groups. So in Target Stroke, we saw similar improvements across different age groups. So if you look at the pre and post Target Stroke numbers and then the difference, pre versus post, you can see a 15-minute reduction in time across different age groups spanning decades or less than 60, and then each decade up to over 80. And then similarly, in another analysis of improvements by sex and race and ethnicity, again, there were very equitable improvements across all groups, men and women, and different racial and ethnic groups. So at least in that program, all of the patients were benefiting, equally regardless of age, sex, race, and ethnicity. Data that I don't show you, but that's unpublished, is there were also similar levels of improvement across hospitals of different sizes as well, because I think that's one important thing that I'll come back to. We have to be careful that when we're talking about improving times, that we're not just focusing on the large academic centers. We want to focus on all hospitals, so all patients benefit, and also because often there are geographical disparities between hospitals too, and we don't want to leave patients in, for example, more rural areas behind. So I'll now talk a little bit about the experience with the SITS ISTR registry, Safe Implementation of Treatment in Stroke. And so this is a global registry covering, not covering Canada or the United States, but many hospitals in Europe and Asia, Australia, South America participate. They've aggregated information for more than 40,000 patients treated with TPA and more than 130,000 total across more than 1,400 sites. They also get post-discharge data on their patients, which is an advantage. And nested within this program, there's the SITS Watch study, which is kind of analogous to the Target Stroke study or our Quicker project. So that was launched in 2013. And their goal was to reduce door-to-needle time by more than 20 minutes. And they were starting from a door-to-needle time of about 65 minutes. They disseminated a 15-item list of suggested interventions, so that's similar to the best practice strategies disseminated within Target Stroke or within Quicker, and I believe results may be available in May. So we don't have the results after the program, but we do have some results published from them prior to program launch, showing where they started from baseline. And they published a paper in Stroke, and they did show that there was some improvement even before launching the program. And this is a bit of a busy slide, but on the x-axis are different years. On the y-axis is different door-to-needle times. And then the different colored bars are for hospitals with different case volumes of stroke, of TPA-treated stroke, rather. And so what you can see is that actually most of the hospitals are kind of around the same, and they did see improvement. It was limited to only the hospitals that are treating more than 100 patients per year. So I think this is a cautionary note that in the absence of a planned program, there's a danger that bigger hospitals will get better at giving TPA, but leave the smaller hospitals behind. So I wrote an editorial about that in Stroke, and I'm glad to see that I don't think this is happening in the Quicker project. So I'll just end with a few reflections on kind of listening to Noreen and seeing the reports and the times and being able to attend some of the learning collaboratives and hearing some of your experiences. I think, when you compare how we've done to how people have done internationally, I guess the most important thing is we're faster, like we're just better. So we should feel pretty good about that, and our patients should feel good about that too, right? Because that's the most important thing, really. That's what leads to better patient outcomes. We're also unique in that these other registries are samples of convenience, as one might say. In other words, hospitals can join those registries. They're not really obligated to, the hospitals that join are the ones that are interested in stroke quality improvement. So, there's a lot of hospitals in Get With The Guidelines, for example. There's more than 1,600 hospitals, but there's more than 3,000 acute care hospitals in the United States. And we know we end up getting about 50 to 60% of all ischemic strokes registered in Get With The Guidelines, but there's another 40% that are treated at hospitals that chose not to join. And it's pretty likely that hospitals that chose not to join are choosing not to join because they're not providing great stroke care and they're not interested in making stroke care better. So what's unique here is we're providing better care to the whole population of a region of Alberta, which is in contrast to the others. What we've done there, therefore, is very equitable, right? I mean, we're focusing on better care for all Albertans. We're not just focusing on care in the hospitals that choose to join our program or are better than already. We're trying to, lift all the boats and make everybody better. We have an advantage over other jurisdictions when we look at systems, because stroke care is really part of a system of care. Starting with dispatch and EMS, and then a hospital, and sometimes transferring and receiving hospital. And we're all integrated, which is an advantage of our Canadian health system. When you look at the United States, where things are very fragmented, it prevents them from working together sometimes to achieve the kind of things that we can. But it's also about champions, right? I mean, the system is there to help people do the right thing. And, it's really important that every hospital has one or more champions where, treating stroke is a passion. I know at Foothills Hospital, we couldn't have come as far as we have without the help of people like Noreen and Michael Hill, Caroline Stevenson, who's our quality improvement nurse. We have a very strong champion in the emergency department, Aaron Bugby, who has really moved systems forward. So it's about making a system that helps people do their job the way they want it to, but it's also about champions and people showing passion for stroke care. So thank you. Well, I was at Punta Cana for a week, so I got really tanned. That's why it looks a little different. And I thank Tom also for pointing out, how far we've come in how little time. But there's no need to take the foot off the accelerator, I think. We don't know what the floor is for how low you can really go, so let's keep all trying to get better and share ways of doing that. Thank you.